Okay, hello everyone. Welcome to this session on diagnosing barriers to vaccination. My name is Sarah Earnshaw Blomqvist and I work at the newly established Social and Behavioural Science team at ECDC in Stockholm.
And my name is Andrea Wirtz and I work also at ECDC in the Vaccine Preventable Diseases team. So welcome everyone here in the audience and also those who are joining us online.
And this session puts the spotlight on social and behavioral science and how social and behavioral science is part of the work of a vaccination program in complement to epidemiological and biomedical science. So, for example, we can use models and approaches from social and behavioral science to diagnose barriers to vaccines, reasons why people may delay or refuse vaccination. So today we will firstly listen to two expert presentations from Bolette Soberg from Denmark and Agnieszka Suchon-Latusek from UNICEF in Poland. And then we will have plenty of time to take all your questions and for our experts to be able to respond to the questions. And we will also take questions from the online participants.
So, before we start with our expert presenters, what we wanted to do is to hear a little bit from you. And for this, we have prepared a short Slido. It's 2 questions. So I believe that we will have a slide with the QR code, and that in the swap card, for those who are joining us online, you should also have the tab with the Slido, and then we can show some questions. We will just await for this to the slide and the QR code so that you can join our short, survey. Yeah. Mm-hmm. Please bear with us some minutes. Yes, thank you very much. Here you have the code to join the Slido. We will await some moments so that you can scan it. Okay, and then we can go to the first question. What can be effective strategies to address suboptimal vaccination coverage in your country? Please write down your answers. If you can be short, the better, and then I believe we will see a rolling list of all the answers that we are receiving from the audience. We will give some time for everyone to reply.
And we really want to hear from you, even online, with what you think are the barriers to vaccination in your country or your context.
Yes, thank you. You are already giving an input with a variety of effective strategies. It's about catch-up campaigns, it's about reminders, recall systems, targeted catch-up vaccinations, identify risk groups and tailor strategies, and this is actually something that our presenters will discuss more. Communication via the media, making it easy. Yeah, there's a lot of answers, and there is a variety of approaches that you are suggesting, so thank you very much for that. In school also, so to do the education in the younger populations also. Access, so some things are more related to the knowledge perceptions of the people, but then also some are related to issues more structural or issues of access. Vaccination ambassadors. Very good. Okay, so thank you very much for this input. We see all these varieties. And I believe we also had a question more on the barriers. Let's see if we can put that one up. Mm-hmm. Okay.
There was one more question, I think. Not this one yet, this is for the end.
No, I think this is from another session.
Okay,
But
we'll
yes,
move on to our
exactly.
speakers.
We move on, and then we will also hear, when we speak about barriers, also the barriers that have been identified in the projects that our speakers have led. And then you can also further reflect in your context which are the barriers that you're seeing for vaccination acceptance and uptake.
Great. Well, I'm delighted to be able to introduce you to our first expert speaker, who is Agnieszka Sochon-Latusek. I hope I've got that right. And she's a social and behavior change specialist at the UNICEF Refugee Response Office here in Poland. And today she will present a case study from her work in applying the 5Cs model from social and behavioral science. The model describes vaccination acceptance and uptake and helps to diagnose barriers and facilitators of vaccination. And the target audience that she's looked at in her research is displaced Ukrainian mothers in Poland. Agnieszka, the floor is yours.
Thank you so much. And I believe I can switch to my next slide. And you can show my presentation.
I think if you go maybe on.
Oh, perfect. And I can see that you can all see my presentation. Okay, so the topic today, and I know you talked a little bit about, and during those 3 days, about vaccination actually, but this is actually a bit unique because we are talking about vaccination in the unique situation of war, of displacement, of mothers who are in the new situation. And I must highlight here that the study that I'll be talking about was done in 2023, so really during the huge escalation of the conflict, right? And during the uncertainty and during the time when we didn't know what will happen. Of course, the uncertainty is continuing, but it was only 1 year in the conflict. So we really used the 5C model, and first, when I go through the project overview, I need to emphasize here that we wanted to focus not only to understand the behaviors and attitudes, but also to ask ourselves why these behaviors occur, and also to prepare something tangible, to prepare some tangible solution for the mothers from Ukraine living in Poland, so we can really help them getting their children vaccinated in Poland. So that's where 5C model comes in, to really understand why these behaviors occur, what are the barriers, and what are the enablers as well that we can leverage in this context. I'm putting here, but I think you will also get the link later on to the full report, and I really invite you to read the full report about the routine immunization and the attitudes, because I will be focusing today on the 5C model and the quantitative research, but we've also done some qualitative research among mothers and also among the health workers who are working in Poland and supporting mothers and vaccinating the children. So it's also an important part. So first, before we start the 5C model, the one thing that is really important, and I want to highlight it here, is about the major challenge. And I have to say that we are all biased here because we are experts on public health. We deal with public health. We are interested in what health institutions are saying, for example. This is not exactly the reality of mothers, especially imagine in this very unique context when they're coming to a new country, when they have to deal with all of the different things like education for their children, like, for example, finding a new apartment, finding a job for her. So they're not going to, for example, Ministry of Health website to look to the vaccination and look how they can immunize their children. So here we ask them, do you know how to get your child vaccinated in Poland? After 1 year of the conflict, and they're saying no. More than one third of the mothers are saying no, that they don't know how to get their children vaccinated. So it's a huge obstacle, a huge constraint that we need to address. So now quickly about the 5C model, and I know that you are already familiar with it. Within the 5C model, I think with this study, with this research, we really focused on the first 3 C's. So it would be the confidence, so really the trust. Do we see the trust in vaccines? Do we see the trust in health workers? Especially when we talk about the new system, so the health workers in Poland and the health system in Poland. The complacency, so how people perceiving the potential risks, and we talked about this a lot, I know, during these 3 days. And the constraints. And the constraints, I think, are the most important. Is it easy to get an access? Do they understand where to go? go? Do they understand who to approach? Those are the questions that we need to ask, and those are the behaviors that we need to identify. And of course, the calculation and collective responsibility. I like that during the slide that we saw that there are some ideas of engaging the communities. I will also talk about this because I think social norms are always important, and especially in this unique situation. So first, constraints, and as I told you before, this is, I think, the biggest part. We ask, what was the reason for your decision not to vaccinate a child? And you can see I'm highlighting here the very first one, I don't know the vaccine schedule requirements in Poland. And I must say, the schedule, the requirements are very similar to those that are in Ukraine. But of course, if we're not listening, if we have all of those different things that we need to care about, we are not sure if this is similar or this is different than in your country. The next one, I don't know where to get child vaccinated. So even though we have the centers, the medical centers where the people can go, and of course there should be informed, there are the doctors who are making, or the nurses who are making the phone calls to the mothers, they still don't know where to go and get the child vaccinated. The next one, and this, I think, is an important one. This is 14% of mothers said that they prefer actually to vaccinate their children back in Ukraine. So imagine how much they prefer to go to the place that is familiar for them. They prefer to go to the space where there is ongoing conflict, but it's easier for them because they actually know the system and they can actually trust that they can have the children vaccinated. The other ones are smaller, but still they're important to highlight. So not an easy access to healthcare services in Poland, or they were advised otherwise by healthcare providers. Sometimes they were still in touch with the healthcare providers in Ukraine, being in Poland. So that was also a challenge for them. And within constraints, we looked at what influences the vaccine behavior within the constraints category. And we have the protective factors and the risk factors. Among the protective factors, we see that the positive effect had the education level of a mother, the Polish language skills, and this is an important one because not only with this research, but with other research that we've done, we see that the language barrier was a huge obstacle. And people are saying Ukrainian language and Polish language, they're similar, but not when it comes to a very serious medical procedures, understanding healthcare providers, being at the doctor's visit. This is a huge obstacle for the mothers. The next one was a full trust in Polish healthcare. That was something that we also leveraged. And having vaccination booklets. Sometimes they were having vaccination booklets, but it was in Ukrainian. And we heard, this is actually from the qualitative research, that they were advised to get the booklet translated, which is also costly. So imagine having multiple children and having to have this translated. The increased factors were age of a child, but also trusting other Ukrainian parents for vaccination information. And it's an interesting one that this is a risk factor because we are really, when we are in the uncertain situation, like mothers from Ukraine being displaced in a different country, we're counting on others who are in the similar situation as we are. The social networks, Facebook groups of this world, Instagram, we are listening to all this information rather than listening sometimes to official institutes, even though we have the trust in the medical system. So the next one, when it comes to 5C, is the complacency. So this is the risk factors, but it's rather a small one, so I don't believe my child needs to be vaccinated, which also highlights that usually the mothers wanted the children to have vaccinated, but there were some different obstacles for them to get them vaccinated in Poland because maybe of the constraints. You've seen how many of them, so not knowing the language, not knowing the system, were the barrier for them to get the children vaccinated. And the next one is the trust, so the confidence, the trust. The 20%, so 1 in 5 said that they're concerned about safety and side effects of vaccines. and they don't, and only 7% don't trust the healthcare system and our medical authorities in Poland. And I want to highlight this with the next slide, that actually we asked additional question about the trust among the doctors, among the healthcare institutions. We asked them, which source of vaccine information do you trust the most? And you can see the first bar there, 74% said that they trust health official institutes, and also 50% of them trust the doctors. And actually we heard that a lot with qualitative research as well. We heard that they actually sometimes prefer and they think that maybe the medical system is even better due to Ukrainian mothers in Polish than in Ukraine. So they want to use this opportunity being in Poland, but they don't understand the system, so they don't know how to get the children vaccinated. But this is something that definitely we can leverage, and maybe with the authorities or ambassadors that were mentioned with the Slido. Worth highlighting, but I mentioned this before, is also the social media and other parents from Ukraine. It's not that significant percentage, but we see that they rely on the information that is shared mouth to mouth or on the groups, and this is the source of information for the vaccination as well, and also for other things when it comes to their children's well-being. I want to mention also this one. This is barriers to accessing services, again, to highlight maybe the constraints. And I talked with this, I talked a little bit about this reviewing the child vaccine records, but I want you to imagine like how difficult it is having the vaccine records also written in a different alphabet. So for the doctors, it is also an obstacle. And I want to just mention it here because we were focusing on the mothers with this study. We actually surveyed almost 2,000 of mothers displaced from Ukraine in Poland, but we also talked with healthcare providers. And I think having this other perspective is really important to understand what are the barriers on the other side. So reviewing my child's vaccine records was an obstacle for mothers, but also for the healthcare providers. I said at the beginning that we wanted to have something tangible. That's why we not only used the survey, but with the 5C model, it helped us to build the communication with the mothers. And we actually built the 3 different types of communication. And with the randomized control trial, we tested them among the mothers. So these are the 3 different messages that we used. And the first is leveraging trust. The other one, access, because we talked about the constraints a lot, and also the highlight of vulnerable situations.
Skip it, we won't have time.
And actually, I know I'm taking a lot of time. And actually this one, the highlighting vulnerable situation, was the one that was proven the most influential. And that was the one that put the perspective for a mother that they need to do it right now because they need to leverage the situation that they are in Poland and they have to get the children vaccinated. Because what we were afraid is that they will be willing to go back to Ukraine and delay the vaccination only to get to the country and only to get the system they're familiar with. So with this in mind, we focus also on doing the behavior interventions, and you have, I think this will be also shared with you. We've done a lot of campaigns. I think the important thing for us is that we brought a lot of health institutes at the very beginning of the process. So we talked with the official health institutes, with Ministry of Health, and we've done some of these events, like for example, RUN, that was leveraging the trust on vaccination. We also invent this a leaflet, but it was also online. And I think the communication was shared online and through the social media was really important because the logo was there from the Ministry of Health, but it was shared on the communication channels that were actually used by the communities, right? And of course, with the RCT method that we've tested, we send it later to the mothers, so they got it, the mothers who had the children under age of 7, so they will be reminded of the vaccination and they can schedule them. Here are some of the conclusions. I think the most important one is the use of the 5C model, because here, as I mentioned, it not only helped us understand why they behave in such a way and how we can help address the behaviors, but also it helped us build something tangible and work on the communication that was later tested with the RCT. And this message focusing on risk awareness was the most effective, and it led to increased intention to get the children vaccinated. And maybe I think the integrating randomized control trial is an interesting one, because we had quite a big sample, so we could use it for the survey and also for the RCT later on. And moving forward, this is something I want to leave you with, and maybe congratulate the ECDC team, because I think it's absolutely fantastic that now the 5C model is also translated to other languages, also to Polish, because we can actually use it with our team that was just established this year, with our BOND team, behavior science team in public health, and they're working right now on the first interventions, the first research on vaccination in Poland. And using the 5C model already in Polish. So this is really perfect, and this is coming really timely. And I hope I will share with you the effect of this work shortly, maybe in the other case at the ESCAIDA. Thank you so much, and now over to you, and I will wait for your questions later on.
Thank you very much, Agnieszka. And we have the pleasure now to introduce our second speaker, Dr. Bolette Soborg. She's the Deputy Director at the Department of Infectious Disease Epidemiology and Prevention in the Statens Serum Institute in Denmark. Her academic and professional focus is on vaccine-preventable diseases, with a particular focus on vaccine hesitancy. And today she will share the experiences in conducting studies on parental attitudes to HPV vaccination and co-leading Denmark's national campaign Stop HPV, Stop Cervical Cancer, which was later renamed to Stop HPV, Get Vaccinated, in collaboration with the Danish Cancer Society and the Danish Medical Association. And this campaign actually successfully rebuilt confidence in HPV vaccination. So over to you, Bolette. Thank you.
Thank you so much, Andrea, and thank you everyone for coming. I know we are competing with a very, very nice lunch, and I hope I can somehow keep it going. I will tell you about our experience in Denmark of applying social and behavioral science approaches in our problems with our HPV vaccination program. And in telling you this, I also tell you about some of my, you could say, travel within this field, as I am an epidemiologist and I'm a medical doctor by background, so this has not been part of my training beforehand. So just to set the scene, the Danish HPV program was launched for girls in 2009 and including boys in 2019. We have vaccines given at year 12, and it's given at the General Petitioner's Office, and it's free of charge until the child turns 18. And since 2017, we have used the 9-valent vaccine solely in our program. And we give 2 doses of HPV vaccine for the under 15, and we give 3 doses if you have turned 15. So we are lucky enough in Denmark to have a very well-built vaccination immunization information system, and we are able to send out invitation letters to the parents before vaccination, and also to send them reminders if the child has not received a vaccine. So we have a very close knit and a personal identification of each child in our system. Then we are also, it's also possible for us to find under-vaccinated groups by linking our system, vaccination information system data to other vaccine, to other registries. So actually, epidemiologically, we have a very good overview of our population and our children in the vaccination program. And then we also we could say, blessed with a high trust in our vaccination program in Denmark, and usually have a very high coverage to all the vaccines within the program. So you should say all would be well. But then suddenly we saw something very different in our program. And what you see in the graph is that the x-axis, you see the birth year of the girls. This is only girls. And on the y-axis, the vaccine coverage for that population. And in red, you see the Danish data, who just suddenly flunks. And it goes down below 50% vaccine coverage. And just to bear in mind what happened in other countries, I put in our Nordic colleagues, which do not see the same kind of dramatic decrease in the same period on the same birth cohorts. And the reason for this is on your right side. It's a TV documentary that was aired in one of the two main broadcasting networks in Denmark, and it's called The Vaccinated Girls, and it shows girls, young women, who all have a range of unspecific symptoms, but all symptoms that are interfering with their everyday life. And what they have in common is that they all got vaccinated, and they do feel that there was a timeliness between the vaccine given and their symptoms onset. So this sparks a lot of debate, and it goes on into social media, it spills over to a lot of other news platforms, and this is the result on a vaccine program. So what we did realize was that we did have a HPV vaccination crisis, but we did not have a plan. And since we do have a lot of epi data, that was not the way to go about it solely. We needed something new. So we needed to understand the behavioral dynamics and drivers in why does this happen. We thought we had a good understanding. We thought we had a trusting population. So what we did, which was new to us, was actually to bring in behavioral science. So first we actually did a media analysis. What are people talking about? What are their main concerns? And where do they go to debate about the vaccine? And with this analysis, we saw that it was definitely adverse events. That was the main problem. And then we went in to do some focus group interviews with mothers, and we asked them about the knowledge and perception and attitude. And it was a lot about these kind of suspected adverse events, and the mothers thinking that they had to make a decision on behalf of their girls. So if they were not taking the right decision, they were harming someone else. And that was very important for the mothers. So they needed to be absolutely sure that they were doing the right thing. And then just to broaden it out, we also did some qualitative survey with an online survey asking the same things, and also, of course, including the fathers. And based on all this sum of information, we could then do some testing of key messages that actually focused on the key findings in these three domains. And it was we needed definitely to address the way that we do surveillance of adverse events, but also we needed to pull back and also tell the people again, why are we vaccinating? Because now the whole thing got skewed, and everyone was only talking about adverse events and about waiting, and not about why they should vaccinate. So that was a very, very important issue as well. And then another thing they also was very clear about was that it was very, very important to them that they knew everyone was standing behind this vaccine, because when things explode, there's always this doctor who will stand on national TV telling everyone that I knew he or she knew the rightful truth, and that was not the same as our truth. So it was very important for the mothers or the parents that everyone was standing behind the message of vaccinating. So we had to team up, and we did that by collaborating with the Danish Medical Association, but also the Danish Cancer Society, which are very big and very powerful in Denmark. which have had a sole interest of preventing cancer. And then the elements of the campaign was also important, because in our media analysis we saw that the discussion was on social media. So it was not done by doing a leaflet or doing a poster somewhere in the doctor's office. We needed to be where the parents were discussing whether to vaccinate or not. So we made a designated Facebook page, and that was actually almost 24/7. It was there was someone there to answer questions, and no one was you could say censored out of the discussion. Everyone had a right to raise their voice, and that was very important as well for us. And then we teamed up with these core partners, but also a variety of networks was important to us. So we're also teamed up with a lot of other patient organizations, and also, of course, important partners in the medical field. And they all pushed the messages, the key messages of the campaign. And then we learned that we also needed to balance what we call heart and brain communication. So also in behavioral science, and that was my learning as well on the way, is that you cannot only push in something that is to deduct a decision based on knowledge. You also have to accept that there is emotions involved in your decision making. So what we did on the social media platform was always, of course, to keep pushing the messages on vaccination, on being transparent on whether there was new studies on side effects or effects, but also to communicate personal stories. And we started out very light by communicating young women who had maybe precancerous lesions, who came forward with their story, said, if I'd had the vaccine, then this would not be my situation right now. And we ended up with the women on the slide, and everyone came forward voluntarily and said, I'd like to share my story. I'm terminally ill with cervical cancer, and I would not have been here had I had the vaccine. And that was extremely powerful. And then we also on the side worked a lot with the press landscape, because, as I said, it was very skewed, and everything was about the media sensation on the adverse events and the girls. And we worked a lot with them to also be able to come forward with our positive stories, and that be whether more took the vaccine or whether there was news about whether the protecting effect was proven. And then into the civil society part, we also were able to actually push the messages. This is also someone who came forward voluntarily. This is a volleyball team of highly skilled young girls, and they were they had the message on their the team shirts, and they were important for a lot of reasons. Primarily also because this is girl in the age of that is eligible for vaccination. They're healthy and they still promote the vaccine. They're not afraid of having it. And in the landscape we had at that time, it was quite brave. And then working with the Danish Cancer Society, they have a lot of volunteers. It's not like we could just tap in and use 40,000 volunteers. They have a vote. It's a very democratic way. They have to vote what they want to use their next year on. And they voted on using their time, spending their spare time on this campaign. It was not easy for them. They knew that there would be a lot of resistance, but even so, they were persuaded to use their time, and they went out to a lot of festivals and a lot of sports events and promoted the messages from our campaign. And then in the end, we also used our key messages actually to meet up with the group that were critical. And we did that by going into meetings and taking a personal dialogue with them, never to maybe agree on the causality, but to show that we were willing to actually help them to move on from the situation they were in. And of course, we helped our professional colleagues who were very pressurized by all the questions about side effects and giving them Q&As and also making sessions with them. So we learned a lot on this. It took us 3 or 4 years, so it was not done in overnight. But we got some very, very important key learnings about the usefulness of behavioral science and how to be transparent in communication, something that we also used during the COVID pandemic. And also always to be accessible to the answer to the questions that people have, even though maybe we don't have the direct answer that they might wish for. So did it help? It did. So we are actually back on the 90% for our first HPV vaccine. We never reached 90% for a second dose, but we hope for one day. And even better, the girls who were not vaccinated or where the mother was hesitant during this crisis, they got catched up, so they also now have a 90% coverage like the rest of the population. So that was a tour de force, and thank you for listening.
Just start with the questions on the floor.
Thank you very much, Paulette. And we propose to do as follow, that we will take some questions from the floor, and we will be also looking at the questions that people have been posting on the swap card. So first, maybe we start with 1 or 2 questions from the floor. If anyone has a question, I see a hand raised. Yes, 2 hands. So please ask your question. Thank you.
Yes, thank you very much. I'm going to be very biased because I'm also UNICEF Social and Behavioral Change Officer coming from Montenegro. Just wanted to compliment Agnieszka on the great work and the great work of our agency, even in the high-income countries, which is very important because people do think that UNICEF is only involved in development areas. So the question is actually going to Polish authorities, anybody in the room that maybe has the data about the coverage of Ukrainian children in Poland. So how many of Ukrainian children have been vaccinated and what is about the real and true utilization of the services. I know this is not something that Agnieszka can answer, but if anybody in the room does have the data, it would be very interesting to see how that also has been changing since the 2022 when all of this started. Thank you very much.
Thank you. Excellent question. And shall I still see?
Yeah, that's fine.
Yeah, thank you so much, and really nice to see the colleague here. Thank you for acknowledging our work, and congratulations, well done for yours. I must say, every time we're talking about this research, every time we're giving a presentation about these issues, we get the same question, and the answer to this is that at the very beginning, when the escalation started, it was very, very challenging to collect the data. So we don't have the perfect data, but what I can say that through this research that we've done and through all of this work, right now there is a change because actually we're working, and you saw the behavioral science and public health team. We're actually in the team we have actually 7 different official public health institutes in Poland, and within those we have sanitary inspectorate who are responsible also for collecting this data on a local level. And now they're doing the transformation from, I think, this May until end of this year to have the better understanding of the data on the coverage, not only from the Polish society, but also the Ukrainian one. So as you know, with the SBC projects, it also takes a lot of time to get to the place where you can see the effects. So we're still waiting for it, but we're getting there with the data. So this is the answer to you. But maybe from the, I don't know, official institutes in Poland, if there is somebody here who wants to complement, please feel free. Thanks.
Thank you very much, Agnieszka, for your comprehensive reply. And I think there was another person waiting for the microphone. Please.
Yeah. So it's a bit frightening that a TV show can have such a great impact. And the curve that you showed, the drop was pretty dramatic. So what I'm surprised about that is that it didn't spill over to the other countries, because even though the TV show was probably in Danish, language isn't such a big barrier anymore nowadays. So do you know why that is? Is that because it was the impact was specifically on certain groups of the population, and so maybe, or is it vaccine specific, or do you have any idea?
Yeah, thank you. I think talking on behalf of my Nordic colleagues, of which I see some in the room, that I think everyone was very worried. And I think they actually made quite an effort to try to reassure that it didn't rub off. And it's not right to say that it didn't. Ireland was very badly hit, and we were like running in parallel. They had a similar issue, and I think this documentary was in Denmark was very important. And I think that before something similar could happen in the other Nordic countries, they knew more what was coming. I'm again looking at my Nordic colleagues, but I think that's it. But otherwise, I think it's just a reminder that it can hit like this specific, even though we think when we go through the 5C model that a lot of things is in place in Denmark, even the trust.
Thank you, Bolette. Sarah, I believe we also have some questions that have been coming in from Swapcard, so
Yes.
hand over to you to see which are the questions coming in. Thank you.
Yeah, we've got a few questions online here. There's a question about routine vaccination for Ukrainian children. Do you know if vaccination is routinely offered to Ukrainian children?
In Poland?
In Poland, yes.
They're the same. Like now they're, if the mother or family is coming with children, they're under the Polish routine vaccination schedule, not the Ukrainian one. So sometimes we've seen that there may be some differences, but they are not in the routine obligatory vaccination between Ukraine and Poland. It's only within the recommended vaccination, but maybe, yeah, from what we know. So they're under the Polish schedule and
Okay.
they offer the vaccination.
Well, that's important to know. And a question from the SWOT card to Bolette. Did you have any problems with organized online information attacks with, for example, anti-vaccination messages on platforms that were open to everybody? There was a... She says, I have not heard of this vaccine or specifically of Denmark being targeted, but it might be relevant.
Yeah, well, thank you. Of course, the grouping was there, and yes, there was also specific targeting. And when Ireland was also hit, we could also see that the targeting was not only local, it was not only nationally. So there was also something coming from outside.
Yeah. And another very interesting question about the Danish crisis. Did anyone follow up with the girls with the suspected side effects involved in the media campaign? It would be interesting to see if their attitudes to vaccination changed over time.
Well, thank you. That's a very interesting question. We did not look specifically at those girls, but I think also drawing maybe a parallel to long COVID symptoms, that we did have a problem, or at least it was very difficult for them to get access to the healthcare system in a way that they found necessary for their symptoms. And I think definitely we learned from that our system, our highly specialized healthcare system, is not really geared to taking care of these more unspecific symptoms coming from different organs. So that was also a learning.
Great, thank you. Should we go back to the room? Are there any more
Yes,
questions here? Yeah.
Bruno, please.
Just thank you to the speakers for the very nice presentations, and also for really fighting against missed opportunities for accessing this very important public health tool. I think in a time of mistrust towards vaccines, it's very promising to see that there is still trust in public health institutions, also from your survey in Poland. And as a public health officials, we cannot betray that trust. Mm-hmm. And this is why what we hear sometimes recently, actually also from the States, puts us in a very difficult situations because we are the one that the population trusts. And for me, it's important if we could start talking more openly on how can we, public health institutions, communicate with the population in a way that is more adequate and it's more close to their needs. I don't think there will be an easy answer here, but it's a field that we need to strengthen and maybe start collaborating also across Europe. And I think the document that we published in all languages is a good starting point. And now we need to collect data and use this data to really work on actionable projects, activities in the countries. But thank you very much for all your work on this.
Thank you, Bruno. This is a really topical question. Do you want to, shall I start with Willette on this question?
Yeah, thank you, Bruno. And I think one of the things that was also a learning for us in Denmark is that maybe also that we need to be a little more brave. We've seen a lot of beautiful presentation at this conference, but sometimes I think we're missing the last step. When you need to convey your messaging to a population, you cannot only use the language and the platform on which you are somehow comfortable. You need to understand that it's the ones who you are messaging to that are the ones who are evaluating whether you are reaching them or not. So maybe we should be a little more brave, and maybe when we target our information, then also do that in a way that might not be the way that you would talk to your colleague or your EP boss. And that sometimes is not easy because you need to tailor it in a way that might not be specifically correct when you use maybe your natural science background. And I think that's very important, especially in a situation as we are in now.
Yeah, thank you. Agnieszka, we'd love to hear from you on this as well.
Lovely response, and 100% I agree with you, and I agree with what you just said. Maybe just to complement, I also believe that we really need to use first of all, behavior science for this, and the 5C model as well, to understand the behaviors, but also to understand the behaviors of healthcare providers, of nurses, of doctors, understanding what are their barriers, and maybe helping them, enabling them in a situation, because sometimes in this unique situation, we have the group who is not speaking the same language. What can we do for them? We heard from doctors that it's actually very difficult for them when we give them the leaflets in Ukrainian, because they don't understand what it says. They want to recommend the vaccination, but they cannot read the card that we're giving to the mothers. So then we had everything translated both in Polish and in Ukrainian. This is a small step, but also helps us understand what are the needs of the doctors, what are the needs of the healthcare providers, how can we support them better, and to build the trust.
Thanks so much. Are there any more questions in the room? Anybody else have something burning that they would like to ask? Yes.
Yes.
Great.
Good morning, my name is Justyna Tymińska. I'm also a member of Polish Society of Family Doctors, and I'm an educator in vaccination communication skills. And in my opinion, we doctors communicate with the patients, not always in a good way. It's also hard to stick to someone's individual perception of vaccination, but this is what you are doing for us. So we need help of media, of public health institutions, because if we even do good things in our clinics, without your help, we will not manage.
Thank you so much, and well done for amazing work. Congratulations.
Thank you very much.
Thank you.
Sarah, are we seeing anything else from the swap card, maybe?
Not at the moment, but I have a little bit of a burning question, which I think is that both of you picked up quite a lot on community engagement and working with these civil society groups that are much closer to the target audiences we're trying to reach with vaccination. Can you say something about how you actually establish and maintain those relationships even in peacetime? Maybe Agnieszka, you'd like to start this time.
Absolutely. Yeah, thank you for asking this question. That's such an important topic, and all of the social norms, the social influences. I think there are multiple ways we can engage with the communities. I think, of course, we need to be, this is what Boleto also said, that we need to be in the places where the dialogue is happening and not only think about the public health or about the health issues. When we think about the, for example, Ukrainian communities living in Poland, they exchange all the time on all of the different topics. We have the groups for kindergarten children, for example. We have the groups where to find a job, where to find a space to live, and we have to be there also, you know, with the health, with the official information about vaccination, and remind them, tell them that if you're looking for something for your child, remember also to get them vaccinated. So this is an important thing. This is the first one, and also to have these ambassadors, to have people who are similar to us, because we respond to people who are similar to us, who are also mothers, who know what they live through. Maybe, for example, when it comes to Ukrainian communities, maybe Ukrainian people who were here before the war and can help them, guide them through the process.
Yeah, thank you. I can say that when we had the campaign running and we had the Danish Cancer Society involved, what we also helped with was actually to provide medical students, young doctors, who would actually go out with the volunteers, for instance, in pharmacies on a Saturday, or to public meetings where you could ask questions. So we actually interacted with them and asked them, what do you need from us in order to feel safe and enact and to do whatever you think is necessary. And then when we are not in that particular crisis situation, there are some networks that are easily kept, and that's the ones that are closer to us, either because they are funded partially maybe from our ministry, whereas the ones that are really civil societies, that's something that we need to do specifically, and maybe have designated meetings where we actually talk and hear what they can. So of course, it cannot be on the same level as during the crisis, where it was weekly.
Great. Really interesting. Really important to make these contacts.
Yes, I would like to ask a question specifically to Bolette. In your presentation, you also mentioned an activity that you did. It was of having a dialogue with the groups that are critical to vaccination, to the HPV vaccine. And then I'm curious how you organized this activity, and what were your learnings from engaging directly with the people critical to the vaccine?
Yeah, thank you. To be honest, it was quite a barrier to go out and be invited in a room where you were actually seen as an unwanted, or at least some kind of an enemy. And what I had, first of all, I had some training. We worked very closely with the WHO Euro office, and I had some training in facing vaccine deniers in public, some training and mediating. But when we were in the room, it was very much about being genuine, being yourself, and then also focusing on where we had some common grounds. We could not agree on causality of these symptoms and the vaccine, but we could agree on feeling, sympathy for the girl who was having a very hard time, and also maybe her struggles of finding her way within the healthcare system, and helping her by designated some specific programs, and also a specific entry into the hospital.
Thank you, Bolette.
We have another question that's just come through on the chat, which is an important one about resources. So the question is to Bolette: how much resources did you need to pull off this huge effort over several years, both human and financial?
Yeah, thank you. That's, of course, a very good question, because there was designated specific resources to this campaign, and that was given from our ministry, but that was actually not the main bulk of funding. The main bulk was actually from the Danish Cancer Society. It's a very, very strong and a very, very powerful organization, and I'm sure it is in a lot of countries. And they have their money from donations, from the public donations that are given through specific, activities once a year, and they actually use a lot of their donations for this campaign. So in that way, it was also a very, very nice partnership.
Mm. And maybe the same question to Agnieszka: How was the work that you did with the 5 C's model in terms of diagnosing the barriers and then developing the campaign? How was that funded?
I mean, first of all, I have to say we were very lucky that at the beginning of the crisis, we had the ECDC, also the Institute of Mother and Child Foundation, who is the local institution that really helped us also pro bono with, for example, the methodology and also the research, starting the research project. I think, of course, the randomized control trials for the research, for having something tangible, was important for us because we had to test something. It can be quite costly, but at the beginning it was easy also to recruit people, and Ukrainian communities were likely to engage in this kind of service, answering questions, even on the sensitive topic of vaccination. So we were very lucky. And then within the campaigns, it was not that heavy in terms of the budget because we were working with the local organization, with the health institutions. So we were doing this work together and as a part of the promotion of vaccination.
Thank you.
Great.
We have one person near the microphone, so please.
I think this might be the last question,
Yes,
Andrea.
exactly. We're running out of time, but please go ahead for your question.
Thank you so much. I'm Ida. I'm from Denmark. I work with Bolette. I would like your take on whether you think we are good enough at communicating our successes within the vaccine area in relation to vaccine hesitancy. Thank you.
Go first.
An important question as well. I'm not sure we're there yet. I mean, in terms of the communicating successes, I think this is something that somebody said before, that we need to work also together among other countries. And I think we're not doing enough of it right now. As you can see, for example, we have colleagues from other maybe high-income countries, middle-income countries that have already this experience. We know that in terms of this unique situation, in terms of, for example, displaced people, also migrant people, we have those communities also in other countries. So let's take this example and let's learn from each other. And I think that would be an important step forward.
And my short answer would be, no, I don't think so, and especially not now. I think it's very, very important that we keep communicating the successes, and I think it becomes forgotten really quickly. So it needs to be said again and again.
And the one thing that has actually come up in other sessions that I've been to during the last couple of days is this idea that even when we are uncertain, we need to keep communicating all of the time. And that is really, really difficult to do.
Yeah.
Okay, well, just to wrap up then, I think we've talked quite a lot about the importance of applying approaches from social and behavioral science to diagnosing these barriers to vaccination and to be able to use that diagnosis to inform our interventions. We've also talked about the importance of involving broader stakeholders, of having these partnerships with civil society to really reach people where they are. Andrea, do you have any summing up?
Yes, and I think it also came out very clearly the importance of having messages that engage with the audience, and to also have the possibility to test these messages and see what works best. And what you were mentioning, not only talking to the minds, but also to the hearts is very important. And then that there is not one single solution, one size fits all, but that interventions need to be tailored.
Exactly.
So yes, I think with that we sum up.
And just, if we can just leave you with a thought, which is the last slide. Can we see the last slide on the screen? Actually, one before that. Sorry, that one, yeah, exactly. So ECDC this year published a new guide, tools and methods from social and behavioral science to support diagnosis of barriers to vaccination and the development of intervention. So exactly what we've been talking about today. And this guide is now available in all EU and EEA languages on the ECDC website. So we really urge you to go and use this. And it includes a library of more than 30 examples of interventions from across the EU, national and subnational level, and a survey tool that you can adapt to your local context and roll out. Do I have a couple of seconds? The last slide? I think we're over time, but if we can have the last slide. And this is also the ECDC Lighthouse. So today, it's a year ago today that we launched the ECDC Lighthouse, which is a community of practice for people who are working or interested in using approaches from social and behavioral science to support the work in infectious disease prevention and control. We're now 600 people on the Lighthouse, and we'd really love to see you there. So I hope you'll join us for loads of important events, small discussions, training opportunities, and much, much more. So see you at the Lighthouse. We'll keep talking.
And thank you, everyone, for your questions, comments, and for our excellent presenters. They're very interesting presentations.
Yeah, thank you so much.